Good evening, everyone. I am Dr. Sanjana Chavan from the Indian Dental Association, and I am delighted to welcome you to our student education program. Today's webinar is focused on the pink revival strategies for soft tissue regeneration. We are honored to welcome Dr. Ria Kashid. She is a distinguished periodontist with a BDS from Sinhagat Dental College, Pune, and an MDS in periodontology from Ternagar Dental College, Navi Mumbai, where she ranked fourth in the MUHs. She has multiple national and international publications, numerous award winning presentations, and expertise in soft tissue grafting, periodontal access therapy, crown lengthening, and regenerative procedures. A passionate clinician and researcher, she is also deeply involved in community oral health initiatives. So let's all welcome Dr. Ria Kashid. Over to you, ma'am.
Thank you, Dr. Sanjana, and the entire IDA team for having me here today. I would just like to confirm I'm audible.
Yes, ma'am, you're audible. You can share your screen.
Thank you.
Yes, ma'am, your screen is visible. You can just make it full screen.
I
Yeah,
think it's
perfect.
useful. Yes.
Perfect, ma'am. Yeah, you can start.
Thank you so much, and thank you to all the participants for joining in today. The topic that I'll be talking about today is pink revivals, strategies for soft tissue management. So, what I'll be talking mainly in brief about today is indications and contraindications for various soft tissue grafting procedures, step-by-step surgical protocols for predictable outcomes. How can you identify the key anatomical considerations to avoid complications and understanding the role of soft tissue grafting in achieving long-term periodontal health and aesthetics? How can you select a case and what should be your post-operative management protocol for optimal healing? So it all started in the year 1962 when Friedman suggested a term mucogingival surgical techniques. These are the techniques designed to provide a functionally adequate zone of keratinized attached gingiva. But as time progressed, a lot of procedures were being added, and a term called as periodontal plastic surgeries came into picture, which was suggested by Miller in the year 1993 and was taken up by the 1996 World Workshop in Clinical Periodontics. So they described periodontal plastic surgeries as surgical procedures performed to correct or eliminate anatomical, developmental, or traumatic deformities of the gingiva or alveolar mucosa. Further, this term was modified as mucogingival therapy, involving surgical and non-surgical correction of the defects in morphology, position, and or amount of soft tissue and the underlying bone. So what procedures are involved when we talk about periodontal plastic surgery? It includes gingival augmentation, perioprosthetic corrections, crown lengthening, ridge augmentation, aesthetic surgical correction, root coverage, papillary reconstruction, surgical correction around the implants, and exposure of the gingiva for uninterrupted tooth during orthodontic movement and lip repositioning. So mainly when we are talking about perioplastic surgeries, we cover main three objectives wherein we are going to deal with the problems which when a patient has a shallow vestibule or an aberrant frenum or when a patient doesn't have adequate attached gingiva. So as we know, our gingiva is divided into three parts: marginal, attached, and alveolar mucosa. The attached gingiva is continuous with our marginal gingiva and it is firm, resilient, and tightly bound to the underlying periosteum of the alveolar bone. So the question lies whether we need an adequate or whether your patient has an adequate or inadequate attached gingiva, and is it necessary to correct if your patient has an inadequate attached gingiva? So various studies have been performed And one of the classic studies that we always refer was given by Lang and Low in the year 1972. And they stated that we need at least an 1 to 2 mm of attached gingiva, which was later supported by Hangoski and Bisada in the year 1980. Then Trey and Bernimolin suggested that if your patient has sufficient thick attached gingiva, we can stop rapidly progressing recession. However, there was another school of thought which was guided by Kirsch and colleagues, Wenstrom, Salkin and colleagues, and they stated that even if your patient has a movable marginal tissue of alveolar mucosa, it can be maintained stable for a longer period of time. Then in the year 1979, Goldman and Cohen gave a concept called as tissue barrier concept. So they proposed that a dense collagenous band of connective tissue retards or obstructs the spread of inflammation than the loose fibrillar attachment of our alveolar mucosa. So they suggested that increasing the keratinized attached tissue to achieve an adequate barrier, which will limit recession if the patient has an inflammation. So what do we want to achieve while we are doing these procedures? Do we want to achieve a healthy periodontal complex? Rather, what we want to achieve whenever we are doing these procedures is a complex which is capable of withstanding the stresses of mastication, tooth brushing, trauma from foreign objects, tooth preparation associated with the crown and bridge procedure, subgingival restoration, orthodontics, inflammation, all of frenum pull. So whenever we are widening our attached gingiva or increasing the zone of attached gingiva, what objectives are we going to achieve is four main things. You will provide your patient an enhanced gingiva so they can effectively remove plaque. It will improve the aesthetics. It will reduce inflammation around restored teeth. And it will also help your gingival margin to bind firmly and more better around your tooth and implants. So the question comes, how do we measure what amount of attached gingiva we have? So there are basic three methods, out of which the most commonly used is our visual method, in which from the crest of your gingival margin to the mucogingival line, we'll measure that entire depth. We subtract the width of our sulcus, the depth of our sulcus, and then that is how you can achieve the measurements of your attached gingiva. Next is our rolled method, in which from your vestibule, you'll move upwards using your probe. And since your alveolar mucosa is not firmly bound, it is a mobile part of the gingiva, it will roll under your probe. However, you will reach a point wherein your gingiva won't move and it is firm. That is the point where your attached gingiva starts, and that is what you're going to measure. And next is the Schiller's iodine test. Basically, iodine has the property to stain glycogen. And alveolar mucosa has more of glycogen content. That is why it will stain your alveolar mucosa and it will give you a demarcation between your attached gingiva and the alveolar mucosa. So next, we discuss what are the problems and where will you do the correction when you have a patient with a shallow vestibule. The main problem are patients with shallow vestibule. What they will face is they're not going to be able to maintain a proper oral hygiene because they're not going to have sufficient space to place their oral hygiene aids. So if your patient has an adequate gingiva, adequate vestibular depth, there is definitely no need to correct. However, if your patient has an adequate vestibular depth, and an inadequate attached gingiva, correction is not necessary. That is, if the patient is maintaining a good optimal oral hygiene, you don't need to correct it and the patient can survive with it. However, if the patient has suboptimal oral hygiene maintenance, in that cases, we can correct. Same way, if the patient has an inadequate attached gingiva and an inadequate vestibular depth, correction is definitely going to be beneficial for such patients. And the third problem that we were discussing was about an aberrant frenum. If the patient has an aberrant frenum, it is going to encroach the margin of the gingiva and it will definitely interfere with the biofilm removal. And if you check, the way we check for an aberrant frenum is by tension test. So whenever you're performing the tension test, you will observe that because of the pull of the frenum, the sulcus always tends to open. So what methods do we have to correct these mucogingival problems? A varied range. It can start with periodontal flaps to the classic free gingival soft tissue graft to our subepithelial connective tissue grafts. We can have laterally positioned pedicle flaps, double papilla laterally positioned flap, and frenectomies. So, when are we going to perform grafting in these mucogingival procedures? Whenever a patient has an inadequate zone of attached gingiva, to eliminate the muscle pull or the frenum pull, to deepen the vestibule, to correct the denuded root surfaces, and to correct ridge deformities and undercuts. The more important part is when we are not going to perform this, is when our patients have a wide and shallow palate, and we have the chance that whenever we are performing or harvesting a graft from the palate, we can easily come across the palatine artery. Or if the patient has an excessively glandular or a fatty palatal submucosa, if the patient has suboptimal oral hygiene and there's an issue with the blood supply, or the patient has an uncontrolled systemic problems. What are the advantages? If you consider free gingival grafts, it has a high amount of predictability, a simple procedure, and we can treat multiple teeth at the same time and can be performed when the keratinized gingiva adjacent to the involved area is insufficient. Whenever you're doing a two-stage root coverage procedure, or even if when we are trying to do a single-stage root coverage procedure. One of the main advantage of these procedures stands that we are going to have two sites. One is going to be our donor site and one is going to be our recipient site. If there are chances that if the root surface is open, there might be slightly or compromised blood supply. The predictability of the amount or the percentage of root coverage that we'll achieve is slightly, less. The patient will definitely have a greater discomfort because of two sites and the retention of the graft. So coming to the patient selection part, Hall in 1977 had noted several factors that need to be considered while selecting a patient rather than just being an inadequate zone or adequate zone of attached gingiva. So patient age plays one of the major factors because we need to consider that the palatal mucosa in the younger group is thinner than that of the elders because the thickness of the orthokeratinized epithelial layer of the palate, it increases with an increase in the age. And the gingival tissue becomes more coarse and dense with the age. Level of oral hygiene is one of the important factors because we need a plaque and a biofilm-free area and an inflammation-free area. Because if our tissues are inflamed, you're not going to be able to place a precise or a clean incision, and you will end up with rugged borders and other flap problems. The teeth involved, the bony anatomy around them, whether the patient has an existing aesthetic problem or the potential aesthetic problem. This potential aesthetic problem is one of the major factors with pre-gingival grafts because when we are doing a pre-gingival graft, the color of the tissue is going to stand out strikingly different from the surrounding tissue because pre-gingival grafts don't tend to take the color of the recipient side. Then whether the patient has an existing recession with aesthetic and sensitivity problems, and rather we need to understand what our patient wants rather than what we as dentists want to do, and we need to also consider what previous dental treatment the patient has undergone, because in a patient who has undergone probably a free gingival or any grafting procedure earlier, we need to wait for minimum of 9 months before we again harvest the graft from any of the sides. One of the most important factors what we need to understand before starting with grafting procedures is anatomy of the palate. So the height, length, and thickness of the graft will definitely vary on the anatomical variations that each patient's palate will show. So once you have anesthetized, what you can mainly do is use a probe to determine the thickness of the graft. The thickness of the palate will definitely play a role has a more important role, rather, I would say, whenever we are doing connective tissue grafts, because we need a minimum of 3 mm of palatal thickness whenever you want to harvest a graft, rather a connective tissue graft. Whenever the thickness is less and we want to harvest a free gingival graft, it is okay. So Reeser et al., they classified the palatal vault into 3 categories. They classified it as shallow, average, and high. The considerations I will come to it slightly later. So the neurovascular bundle from the palate, the greater palate and arteries, they're located at a distance of 7 to 17 mm from the cemento-enamel junction. And we need to consider this whenever you're harvesting a graft because you don't want to end up nicking the artery, which will end up in intraoperative bleeding. So the greater palatine foramen is palpated to determine the area to be left free when marking the incision so that we do not violate the space of the neurovascular bundle. Though there are many techniques such as you can use an ultrasound, MRI, which are newer techniques to locate the foramen, but these techniques clinically are not possible for us to use every day. So what we depend or rely mainly on is palpating the greater palatine foramen and then making sure that we are away from that area and we do not ending up nicking the artery. So if your patient has a flat palatal wall, what you expect is that the approximately from the CEJ, the neurovascular bundle is going to lie somewhere at around 7 mm. If the patient has an average wall, it will be at 12 mm, and if the patient has a high wall, it will lie somewhere around at 17 mm. So, and as we move anterior, from basically from the molars to the anterior teeth towards the canines, the neurovascular bundle follows its trajectory to the nasopalatine foramen, and hence the incisions should be avoided in the anterior superior area. What I'm meaning is, if we see over here, the artery is moving like towards anteriorly. So you need to be careful where you're going to place your incisions. So next, to perform the graft harvesting safely, the most safe role, what we consider is the area from the second premolar to the second molar. And the area from the first premolar to the canine is considered as the least safe. Even if you tend to involve your first premolar, we need to keep in mind that our incision should lie strictly beyond the distal surface of the canine to avoid the palatine nerve and the artery as they come closer to the cemento-enamel junction in the anterior area, and they're almost like at 2 mm from the margin of the gingiva in that area. Why palate is routinely used as the donor site? Grafts, they can be performed from edentulous ridges maxillary tuberosity palate, while palate being the most frequently used because of the large dimension of the graft that we can obtain, and also the histologic similarity between the palatal mucosa and the keratinized attached mucosa of the alveolar ridge. Coming to other important factor, that is the phenotype. So when we're talking earlier, you must have heard that gingival biotype was a term that was more frequently used, but now it has been changed to periodontal phenotype. Basically, it involves the combination of both our gingival phenotype, that is a three-dimensional gingival volume. Then you're going to consider the width of the attached gingiva and the thickness of the gingiva, and you are also going to consider the thickness of the buccal bone plate. So basically, you can classify the phenotype into three types. The first being the thin scalloped gingiva, wherein your gingiva, you will have a narrow zone of the keratinized tissue, and the gingiva is going to be thin. You will have a slender crown and a subtle cervical convexity, and your contact is going to lie more near your incisal edges. And whenever you check using a probe, your probe is going to be visible. Next type that comes is thick, and thick it can be a thick scalloped gingiva or a thick flat gingiva. So if there's a thick scalloped gingiva, the gingiva is going to be thick and fibrotic, but however, you're again going to end up with slender teeth. The gingiva scalloping is going to be pronounced, and the main difference between a thick flat and a thick scalloped is going to be the band of the attached gingiva. So with the thick scalloped one, you're going to have a narrow band or a narrow zone of keratinized tissue again. And with the thick flat, you're going to, as you can see over here, you have a broad zone of keratinized tissue. and your teeth will be slightly squarish. The contact will be near the gingival margin, and the contacts are going to be large. So how can the periodontal phenotype be assessed in a standard and a reproducible way? One of the most common ways to check is we insert a periodontal probe into the circle, the way we used to measure the gingival sulcus. And if the probe shines through it, that is, the probe is visible, we consider it as a thin gingiva and say that the thickness is somewhere less than an mm. And if the probe is not visible, we can call it a thick gingiva. Here you can see the probe is visible, that is why we have classified it as a thin gingiva. Next, one of the main things that you need to consider is thin phenotype increases the risk for gingival recession and is more prone for increased recession lesions. However, you can maintain this if the patient has an optimal oral hygiene. Coming to the next point, criteria for selection of the technique. First things, the surgical site, as we already discussed, it has to be free of the biofilm calculus and inflammation because we don't want rough incisions, we want precise incisions. Next, the blood supply should be adequate and to the donor tissue. So if we want an sufficient blood supply to the donor tissue, one of the main things that we want is we create a very healthy and a wide periosteal bed so that the tissue can lie and rest on it. If at all we are going to attempt a root coverage procedure, we need to consider the fact that the graft, where the root is denuded, that area, the graft is not going to receive any blood supply. Hence, it is advisable that if the patient is comfortable and if the aesthetics are not a concern and you want to increase the width of attached gingiva, you can definitely use augmentation apical to the recession. And if we want to 100% achieve coverage, and that is our main goal, we can consider using techniques such as a pedicle graft, because in pedicle techniques, pedicle flaps, the blood supply is going to be maintained. The next thing that is important is anatomy of the recipient site and donor site. So the presence or absence of the vestibular cleft is definitely an important anatomical criteria when we are considering the recipient site. If gingival augmentation is indicated apical to the recession, then there must be an adequate vestibular depth for us to perform the procedures. However, when we want to augment the attached gingiva and we also want to increase the depth of the vestibule, our FDGs and CTGs do a very excellent job while doing this. Then the availability of the donor tissue is one of the important factors that we also need to discuss. The palatal tissue thickness, as I already said, if at all you're doing a CTG, a minimum of 3 mm thickness is very important when you want to harvest a CTG. And also in the recipient side, we need to check if the patient has a thin or a thick biotype, because that will somewhere decide where you're going to place your incisions and how you're going to harvest prepare your recipient site. Next comes the stability of the grafted tissue at the recipient site. So the thing that I always say is you need to stabilize your graft with minimal number of sutures. It should be minimum sutures and maximum stability of your grafted tissue at the recipient site. And lastly, minimal trauma to the surgical site. So we need to understand that our periodontal plastic surgeries are meticulous, delicate procedures for the management of our oral tissues. And unnecessary tissue trauma, if we give poor incisions, flap perforation, tears, or excessive placement of sutures, can lead to tissue necrosis. So always use sharp contoured blades. The diameters of the needle should be small. Use resorbable monofilament sutures. Use your 50 or 60 monofilament sutures because they'll make your surgery or traumatic. Coming to principles of three main principles that we need to keep in mind whenever we are doing these procedures is never ever incise or harm your existing keratinized tissue, because whatever is there, we always want to preserve. Exposing the bone to increase the zone of keratinized gingiva is contraindicated because we cannot place our grafts majorly on the denuded bone because we want to place it over the periosteum. We want it to survive, and the periosteum is what is going to give the blood supply and nutrition to your graft. Next, when an adequate zone of attached gingiva exists, vestibular depth is not a factor that we consider. So basically, the published reports of gingival grafting became appearing in the American literature in the 1960s when Bjorn in the year 1963 started with the free gingival graft, or neighbors suggested grafting in the year 1966. Yet we say it was not until Sullivan and Atkins published their classic trilogy on the indications, techniques, and wound healing following grafting that grafting became a popular procedure, and their articles were so complete that the principles, techniques that they outlined back then are still valid today. So coming to the most frequently used grafting technique, or the type of grafts that we use, are the free gingival graft. The free gingival graft, the technique was first introduced by Bjorn in the year 1963, and since then these grafts have been extensively used to increase the width of attached gingiva with successful results. It remains to be the gold standard technique for increasing the width of keratinized gingiva. And the advantages that it gives you is the graft predictability and the technique simplicity. When will you use your free gingival grafts? Whenever you want to increase the keratinized gingiva around the tour, around your peri-implant area, when you want to increase the vestibular depth, cover recessions, and increase the alveolar ridge. So, coming to the cases, so this was a 30-year-old female who reported to the clinic, and her main chief complaint was she was having sensitivity and a constant dirt or a brownish deposit accumulation in her lower anterior area. So we first did her root planing curettage. We reinforced oral hygiene instructions for her, and after proper evaluation, we decided that in her case, we are going to do free gingival graft, and we'll slightly try and increase the vestibule and also achieve coverage. So first we took the pre-operative measurements for her so as we can decide the what length or what dimensions of the graft that we want to harvest. So the basic thing when we prepare the recipient site is what we need to understand, that we want a firm connective tissue bed so that the graft can rest on it. And basically, whenever you're preparing a recipient bed, there are two methods that you can use. One is at the existing mucogingival line, you place an horizontal incision. Your blade has to be parallel to your bone, and you start dissecting vertically downwards. A classic smiley shape is what you expect when you start doing this. The second way that you can perform is you from the existing keratinized, again the mucogingival line, you give two vertical incisions. Again, you go down and you dissect the area, and then these two incisions you join at your mucogingival line and you create a recipient bed. While preparing the recipient bed, what we need to consider mainly is that you are going to prepare a bed that is almost like 50%, or you say 6 to 8 mm larger than your expected size, because if there's a free muscle pull or any free nerve pull, then the site is going to contract and the results that you're going to get are going to be lesser. So once you have used any of the technique, either you give a single horizontal incision or you use the three incision technique, what you do is make sure that there are no muscle attachments left in the vestibular area. And if required, the vestibule part using sutures, you can use your same monofilament sutures and you will suture that area to your vestibule. Then you can either take the measurements directly using your probe, or you can make a sterile 10-point template as you can see in this picture. This is definitely larger, but then we trim and we get a measurement that is ideal for the site. Once you have done that, you transfer those measurements to your palatal site, to your palate, and then the classic technique which Bjorn gave for harvesting your fees-in-level grafts was a two vertical, two horizontal incision technique, where you can see basic you form a rectangle or the shape that is there, two horizontal, one, two vertical incisions, and you take you elevate the graft basically from one end, and then you keep on dissecting it. And as you dissect or start slicing the tissue, you will gain more accessibility, and then at the end, you can harvest your tissue. So this is the harvested graft. The main criteria, the main thing that you need to make a note is that your graft should not be too thick or it should not be too thin. The ideal graft thickness that we say is somewhere it should be between 1 to 1.5 mm. What will happen if you have a thinner graft? Definitely the graft is not going to survive, it is going to necrose. And again, if you have a thicker graft, what will happen is it is again not going to get blood supply and nutrients from your recipient side, and again the chances of it surviving become less. So what we say is we want an ideal thickness of 1 to 1.5 mm of your graft. Definitely, when you harvest your graft, if it is thick, just trim it to the edges. Make sure that you trim the edges and make it thin on the edges so that it adapts properly, and then you're not going to have a bulgy appearance. The next comes suturing of your graft. So basically, you use your monofilament sutures. While suturing, what we want to make sure is that we don't leave any dead space. So whenever you have prepared this recipient site, before you move to your pallet or the donor site, what you do is you place a moist saline soaked gauze into this area, so that the area here is not dehydrated. And then once you reach the stage where you have harvested your graft, you've trimmed it, and it is ready for being sutured, you just remove that gauze. You make sure that there's no excessive blood clot that is present, and you start suturing. So while you're suturing, what you can do over here is start first stabilizing the graft from the coronal area. And what we usually do is we try and suture through half of the papilla. However, what I think from my practice is pierce your entire papilla through and through. I mean, go entire lingual like a proper interrupted suture, come back to the facial, and then suture it over here over the graft, because that is definitely going to give your sutures more strength, because these sutures, they're going to be for somewhere around 2 to 3 weeks, and they need the strength to hold your graft. Once you have secured your graft from all the four sides, what you do is take a suture from the vestibule and sling it around the tooth. Basically, sling it around the tooth and then compress your graft so that there is no dead space left. Uh, Again, there are multiple ways when you wherein how you will want to cover your recipient side, sorry, the donor side. So one of the most common or traditional techniques that was using a Holly's retainer. However, with Holly's retainer, the problem is you need to call your patient an appointment prior to get the impressions. Then you need to schedule another appointment because you don't want the chaos during your appointment. See, the retainer is not fitting. So there are multiple options that I will discuss later. But however, if you are using a Holly's retainer, you need to make sure that it is fitting properly, and it has definitely has a spacer on your planned recipient side so that you can put any periodontal dressing over there and use it. So this is the follow-up picture wherein you can see that the graft has been taken up. However, that is the main disadvantage of our freeze gingival grafts, that there's no color matching that takes place. And this is the palette. So from this stage, using our pre-gingival grafts, we have definitely increased the depth of the vestibule, and we have managed to achieve coverage. Coming to the second case, so this was a 32-year-old male again, and his problem was he had the concern, the classic what our patients concern, कि मेरे मसूड़े नीचे जा रहे हैं. So again, after reinforcing oral hygiene instructions and proper scaling and root planing and preparing the case for grafting, what we decided was we were going to do a free gingival graft, because again, he had a thin biotype and a narrow band of keratinized tissue. Again, we did the same thing. We took the dimensions, marked the recipient side. So here what you can see is we have done a proper horizontal incision, and you have that proper smiley face over here. This part of the gingiva which is going to cover, we did not want to nick the entire existing keratinized tissue. So what we do is raise kind of partial thickness, or just prepare the bed by scraping slightly the tissues. Again, you take the measurement, pass it on to the palate. Another trick for getting a point wherein you can easily start elevating your tissue and you don't get stuck, or you have that problem the graft is not separating from the edges, slightly extend your incisions one, not even an mm, 0.5 mm from your planned donor set dimensions. So whenever you do that, you make sure that the graft is released from all these 4 points and it is not getting stuck anywhere. So you can elevate your graft from here and start slicing it and separating it from the underlying periosteum, and you have the graft in your hand. Again, we took these are the graft dimensions. We have placed the graft, sutured it in the same way from the interdental area and and a sling suture to reduce the dead space. In this case, for closing the donor site, what we have used was cyanoacrylate. So basically, it is like a tissue adhesive which seals or which clots when it comes in contact with the blood, and it has shown to have slightly analgesic properties. So this is again the pre-op wherein you can see the graft being taken up, the palate, and from pre-op to post-op, root coverage being achieved. Coming to the second most used technique, connective tissue graft. The connective tissue autograft was first described by Edel and is based on the fact that connective tissue carries genetic messages from the overlying epithelium to become keratinized. Uh, However, what we need to keep in mind is only connective tissue from beneath the keratinized zone can be used as a graft. The advantage of this is that the donor tissue is obtained from the undersurface of palatal flap, which we can again suture back, and that is why, however, healing of the palate is going to take place by first intention. However, when in our free gingival graft cases, the healing takes place by secondary intention. In this, once you suture back your flap, the palatal flap back on your donor site, the healing will start by first incision. That is why your patient is going to have less discomfort post-operatively. And another advantage of the CTG is that improved aesthetics can be achieved because CTG, it will give you a better color match of the grafted tissue to the adjacent area. Again, the indications of CTG, coverage of recession, increased thickness of the peri-implant soft tissue. In cases of immediate implant placement, dehiscence of the peri-implant soft tissues and increase of the alveolar ridge. So this 28-year-old female reported with the problem of her roots being seen. Again, her masuda, the gums were receding. That was her problem. So in her case, we decided that we are going to do a CF with CTG. So basically, you again take the dimensions. And so whenever you're doing CF with CTG, CF, basically you can do coronally advanced flap in two ways. This technique described here is your trapezoidal flap, and this is your triangular technique. So whenever you're doing a CF or a coronally advanced flap, you first measure your amount of recession. You add like an mm to it, and that you leave that much area from your crest of the interdental papilla. And from there, you will give two horizontal incisions on both the sides, and you give again two releasing vertical incisions. One of the main things that you need to note here is till the point of your recession, you are going to raise a split thickness flap. Then once you move above for like 4 to 5 mm, you will raise a full thickness flap. And again, you going beyond that, you will raise a split thickness flap. Now, why split full split? Because you want to use this area for advancing your flap. So you want to make your flap mobile. That is why it is going to be a split thickness flap. So it becomes mobile and you can pull it or advance it coronally and you can suture it over here. The other technique that you can use is a triangular flap technique, wherein again you measure your recession, you leave that area, and you again give directly two vertical releasing incisions. Like here, you use first horizontal and then vertical. In the triangular case, you directly give your two vertical releasing incisions. You raise your flap in the same split full split technique, and you're ready to go. So this is the recipient side that was prepared. Then you can see a split thickness flap over here, a full thickness, and again a split thickness flap, so I can advance this area. So coming to harvesting CTGs, there are multiple techniques that have been proposed. One of the techniques that we used in this case was a Herzler's single incision technique. So in this case, you first give like a single direct horizontal incision, a 90-degree incision. Then you turn the blade slightly at an angle and you give like a split thickness undermining incision. And then you separate the graft from the palate, and that is how you achieve your connective tissue graft. So you give an incision, and that is how from the pouch you're going to harvest your CTG. You suture it back, the graft was placed, and the flap was sutured after advancing coronally. And these are the pictures that follow. So using a CTG, we have managed on covering this amount of recession. So next case is wherein a 38-year-old female, she wanted to get her premolar, that is a 2-4 replaced. However, what you observe here is a defect. And what was planned was a bridge for her in 2-3, 2-4, and 2-5 area. So after proper evaluation, what you can see here is she has a horizontal defect and a vertical defect too. So ridge defects are basically classified using the Siebert's classification, wherein in class 1 you only have a horizontal defect. Class 2, as you can see here, has only a vertical defect. Whereas a class 3 is a combined defect wherein you have a horizontal and a vertical defect. Hence, we classified this into a Siebert's class 3 defect. And then in this case, we decided on pedicling the flap. Basically, this is the buccal incision that you can see with the buccal flap design that we had planned. And this is the palatal flap design. Then this is the flap reflection pictures basically, and we harvested a CTG from here. We had planned on doing grafting because we also wanted to do a horizontal augmentation. So first we performed a corticotomy, and then we placed a graft over there. After that, we also planned on placing a PRF membrane. So the PRF membrane was obtained, and we placed all the three, the bone graft, the PRF membrane, and the graft, and this is how it was sutured back. And this is the end result when we have given the patient the prosthesis, and she has a nice scallop. Again, a similar case, but this time it was a 34-year-old male who, when he first reported, looking at the gingiva and everything, we made a CBCT. Earlier, it was planned that we would have to the patient wanted an implant, but then after evaluation, we found a ridge defect, and then we would need a heavy grafting and a lot of procedures for which the patient was not ready. So we decided the patient wanted something very quick because he was uncomfortable moving around with the cap. So what we planned was again a bridge using 2-1-2-2-2-3. But again, before that, we had to perform an augmentation procedure. So again, in this case, this was a Siebert's class 1 defect because it was only a horizontal defect and not a vertical defect. Again, we raised the flap. In this case, we harvested the graft using the Edel's trapdoor technique. So basically, Edel has proposed multiple techniques, out of which two I will discuss here. So in the first technique, what he proposed was use a 15-number blade. You raise a partial thickness palatal flap, and you create like a door for the flap. And once you have opened a door, like you can see over here, we have opened a C-shaped door. After that, again, you separate your connective tissue from the underlying bone, and you have the graft to harvest. The second technique that he suggested was, again, we open a door. But in this time, your incisions are going to be deeper. You're going to raise a thicker flap, and your graft is the part of your graft is going to be attached to your door, and you slice it and you harvest the graft from the flap that or the trapdoor that you have opened. So in this case, we use the first technique wherein a partial thickness flap was opened. There's a graft. The connective tissue graft was then harvested, which you can see over here. Again, we place the bone graft, again place the CTG, and we have sutured it back, and then we place the crown. Coming to even if you have done the surgery correctly, what you need to mainly instruct your what matters is post-operative healing. So basic instructions stand the same, that you will tell your patient they're not supposed to eat for 3 to 5 hours, mainly not brush for the first 24 hours, do not rinse spit, and main thing is that you advise your patients to not touch the area, be it your palate or any site, or your donor site and recipient site, basically. Then swelling can be there, especially in the lower area, and it is normal. And ask your patient to advise you apply ice continuously immediately after the surgery, and for the next 1 or 2 days, it should be fine. Then afterwards, if there's a swelling, just advise the patient to open and close. It should help. Main instructions which come is pertaining to your grafting site. So you inform your patient that a protective dressing has been placed at your donor side, and please avoid disturbing it. They will have some soreness and some bleeding, and it is not a concern even if a part of it comes off. And if they feel that it's uncomfortable, ask them to come back to you, and you can re-apply the dressing. Also, the color of the tissue will be more red than normal earlier. The redness will subside. It will be red, then the graft will turn pale, and it's a normal part of the healing, and that they don't need to be worried about it. Advise them specifically not to pull their lips and cheeks so that they are not giving unnecessary tension and pressure to the graft. Oral hygiene, obviously, first 24 as no brushing. After 24 hours, you tell them to start brushing everywhere except the surgical area. You need to inform your patient that for the next 2 to 3 weeks, they're not going to be brushing specifically in that surgical area. They can brush everywhere. And to maintain the oral hygiene in that area, what they're going to do is use chlorhexidine. They're going to pull it in that area if you can, and hold it in that area for like 60 to 90 seconds, and then gently spit. You will also advise your patient to be on soft diet. You avoid definitely spicy, crunchy food, and definitely avoid smoking, vaping, and alcohol. A step further, what we advise is do not let your patient, I mean, even if your patient is washing the face or doing something, don't continuously press and apply pressure in that area. Sutures we usually remove for 2 to 3 weeks, but make sure you see your patient every 7 days, because that is how you can have a check whether they are maintaining the oral hygiene. Coming to complications, so the most frequent complication during graft harvesting is bleeding during or after the surgery that can be generated by a lesion in the palatal vessel. And other complication that may occur is paresthesia or anesthesia in the palate due to invasion of the greater palatine or the nasopalatine nerve. So the order in which these complications can occur is, while giving the incision, we can injure the greater palatine artery and end up in bleeding. While flap preparation also, we can lacerate the flap or a greater palatine injury. During harvesting the graft itself, which is very common with CTGs, that you don't get sufficient quantity of graft can happen. Hemostasis bleeding can occur whenever it is said that in trapdoor you have 33% chances. In FGGs, you have 25% chances. Coming to during the healing procedure, the bleeding can occur, flap sloughing or necrosis, infection, sensory disorder, bone exposure, and late complications can be something like an epithelial cyst formation and persistent sensory dysfunction. So injury to the greater palatine nerve, this is something that is greater palatine artery, sorry. This is something that is most commonly occur. It can most commonly occur during harvesting the graft, and that is why what I discussed was you need to have a thorough knowledge of the palatal anatomy. You need to remember the tentative distances, where your artery is going to go from you, the course of your artery, so that you are away from your artery and you don't end up nicking it. As I already said, ultrasonography is MRI. Though these techniques are available, they are not feasible for us to use in the clinic. So if at all you encounter that you have nicked the artery and you have bleeding, the first thing that you will do is apply a firm pressure. Then you can take any hemostatic agents and apply pressure and check. If it's a minor bleeder, it can be managed with that. Even if your hemostatic agent is not helping you, what you can do is electrocauterizing. Just cauterize and coagulate that area, and the bleeding should the bleeding should be taken care of. At times, if we end up having not the proper medical history, you and the patient is on anticoagulants or some medicines like that, we there might be unusual bleeding that you might find. So that is why it is necessary that you make sure that your patient has stopped their blood thinners at the appropriate time. So next thing that happens is uh, what we can talk about is flap laceration. So whenever you are harvesting a CTG, what we do is we tend to harvest a palate, open a palatal flap. If you're talking about a trapdoor technique, and in the first technique where we are opening the door, and then you are going to harvest the door from the sorry, the graft from the palate. So in during it's a very sensitive procedure and a meticulous procedure. So you need to be careful that you don't lacerate or tear that flap, because you have to suture it back to its place. Minor flap lacerations definitely don't affect the healing. However, if there's a major flap laceration, then the advantage that our CTG has, that it's going to be a primary closure. It might not be a primary closure and it can end up in the secondary closure. And hence we say that it is necessary that we have a 3 mm palatal mucosa, so that we can at least have 1 mm thickness of our palatal flap, and then you harvest the CTG underneath from that. This thing is not mainly what you will have with FGG, because FGG definitely undergoes a secondary healing mechanism. Uh, the next problem that we will talk about is inadequate graft. So, owing to the anatomical consideration, what I mean, first thing, harvesting CTG is like a critical or a technique sensitive procedure, and majority of the times what happens is that you don't get a sufficient amount of graft. If the palatal mucosa is thinner in the first molar area, there is a problem wherein you're going to have harvesting the graft. And again, the same thing, that if you don't get a sufficient, if the palate is thin and there's no sufficient amount of thickness, you're going to end up in a thinner graft, or a graft that is more probably of a fatty tissue, or something like that. Then comes him inadequate graft quality. One thing is that you don't have sufficient amount of graft, and the second thing you might have is the graft quality. So the tissue graft abundant in fibrous connective tissue is going to be more firm, more stable, easy to manipulate, rather than a tissue which is flat, fatty or glandular in in composition basically. And what we want is a fibrous connective tissue and not a fatty connective tissue. And this is usually seen that especially in the molar areas, as we go back, the tissue turns to be more fatty. Pain definitely is one of the most postoperative complications, or a complaint that your patients are going to complain. It is going to be definitely less when you're using the single incision or the Herzler's technique, single incision or the trapdoor technique, because you're going to end up closing the surgical site, and that is why the healing is going to be by primary intention. However, if you consider pre-gingival grafts, in that case, your healing is going to be by secondary intention, and your patients might complain of more pain. One thing that I want to discuss is flap sloughing or necrosis, rather the tissue sloughing or necrosis. Again, we have spoken ki if the thickness is less, that is why achieving a proper thickness of the graft before suturing it is an important factor whenever you're doing grafting procedures. And post-operative persistent sense infection, if I have to say, infection is a very rare possibility when you're talking about tissue grafting, because your patient is already under antibiotics and a lot of things. So having infection is a rare thing. One of sensory disinfection, patients can have something even after 2 weeks of your free gingival grafting. And there are studies which have stated that it might take in total of 8 weeks for your patient to come have normal sensory function back, because whenever you're preparing the site, though not your main nerves, but the nerve endings, you can end up lacerating. And epithelial cyst formation, so it is a rare development that an epithelial cyst formation after a CTG can take place. And it has been seen that if your tissue has been locked inside or something like that, the cyst formation takes place. So coming to the risk of post-operative complication, definitely double plus means that there's a more graft, more possibility. So CTGs, connective tissue graft, subepithelial connective tissue graft, they definitely have more risks when of injuring the nerve, excessive bleeding, more major problem of the inadequate graft size and quality, which we don't have with FGGs because you're harvesting a graft in toto. One of the other techniques of harvesting a CTG can be like you harvest a thicker FGG and you slice the above epithelium and use the underlying connective tissue as a CTG. However, the risk of prolonged bleeding is more with FGG, and patient discomfort is definitely more with FGG. So, concluding, the main thing that lies in all of these grafting procedures is that we have a thorough knowledge of the anatomy of the palate. It is and the knowledge anatomy of the palate is elementary to perform harvesting procedures, be it free gingival graft or be it connective tissue graft. And locating our greater palatine foramen, the nasopalatine foramen, and the neurovascular bundle can greatly reduce these complications. And there are multiple surgical techniques which we can use to harvest free or connective tissue grafts. However, the selection of that technique has to be mainly decided on the anatomy of the palate, the size of the recipient bed, the location, the type of healing that we are desiring are some of the factors that you need to consider. I hope I've been able to do some justice. So thank you. And this is the end from my side.
Thank you so much, ma'am. I think we are having some doubts. I'll just read out.
Yes.
If anyone is having any doubts, you can text in the chat box. Okay, so there is a doubt. Ma'am, after the graft placement, still the
Hmm.
recession is present in some of the images which you have shown. So how is the graft going to cover it?
So there's a concept which is called creeping attachment. Basically, if your patient is doing proper oral hygiene and all of those factors, main thing that you need to consider is in the first case, I'm sorry, I don't know who has asked this question. Is we need to go back and go to our Miller's classification. If you see, the recession was almost approaching to your mucogingival junction, and that is where our Miller's classification plays a role. Key that is going to help me predict. See, I one of the main things with soft tissue grafting is that the procedures is not going to be predictable. But we can definitely do something better for our patients. And one thing that we need to understand that there's a concept called as creeping attachment. So it is not something that is going to happen in like a week's or a two's time. But then over a year, if the patient maintains proper oral hygiene, proper brushing, and everything, there are chances that the root coverage, I mean, there's a coronal migration of the gingiva, and the recession can get covered.
Okay, there is another doubt. Graft is taken mainly from which side?
You cannot decide the side. That is, see, if you're like in one of the cases when I was doing the procedure on the second quadrant, I have chosen the second quadrant because then even if you're performing a surgery, it's an intentional injury. So all of the trauma stays to one side. Basically, if there's an option right or left, you need to decide uh, first measure wherein if there's any variation in the palatal thickness, which area is going to be more comfortable, which has more thicker area, so that you have more tissue to be harvested. And in the end, somewhere or the else, I'll say that the surgeon's preference also matters. Some surgeons might be comfortable because you need to the first quadrant or to the second quadrant. You need to evaluate your palatal thickness. If it's both on the same side, you can definitely go according to your comfort.
Okay. Then someone wants to know that if the patient comes with post of infection and pain, what medication, I think, what medication and treatment are we going to give?
As I said, the chances of infection are very less because you are already going to be giving patients antibiotics. So the chances of infections are almost zero. There's a study that has said that the chances of infection post doing the grafting procedures is almost 0.08%. So I think that is very less. And if the patient comes with infection, it depends basically. It can either be sloughing of your palatal wound if the patient is not, in case you have kept the wound open. I mean, you're not using your classic Hollies or Essex retainer and you've kept the wound open. So that time, all you do is just debride the area and you put a gel sponge and you suture it over.
Okay. Uh, okay, there's another question. Is the palate only the site for the grafts? Can you give more some and we don't have more options due to bad oral hygiene? Like example, due to tobacco chewing, where we'll take graft. So basically, you need some examples, I think so.
I did not get the question, I'm sorry.
Actually, I also didn't get the question.
See,
So
as I already mentioned, I mean, palette is the most commonly used site because definitely your palette is a big structure. So you can harvest a greater amount of tissues. If you go back to your tuberosities, that area is that already so small, the amount of graft that you will be able to harvest is very less. And if you have palette, why don't you use palette?
okay, I think we are done with all the doubts. Okay. So thank you so much, ma'am, for your time and efforts. It was a wonderful, insightful webinar. Thanks a lot. And thank you so much. I think we'll end the session in few minutes. I'm just waiting for the participants to fill in the certificate form. Please, everyone, kindly fill in the form to receive your certificates.
Thank you, Dr. Sanjana, and thank you, the entire IDA team, for giving me this opportunity to share whatever knowledge I have regarding this topic. And thank you, everyone, for joining in.
Thank you, ma'am. Thank you so much. Good night, ma'am.
Good night. Thank you.
Yeah. For all the participants, please fill in the certificate link which has been shared in your chat box.